Hi, I'm Dr. James C. Wittig. I'm an orthopedic oncologist and sarcoma surgeon in the New York metro area. Today we're going to be speaking about soft tissue sarcomas, also known as malignant soft tissue tumors. These are cancerous tumors that arise from the soft tissues of the extremities or the pelvis. Can also arise from other organs, and we're going to concentrate on those that arise from the extremities or the pelvis. And these soft tissue sarcomas include liposarcoma, malignant fibrous histiocytoma, which is also called undifferentiated pleomorphic sarcoma, synovial sarcoma, fibrosarcoma, rhabdomyosarcoma, and leiomyosarcoma. Those are your main types of, or your most common types of soft tissue sarcomas. For more information about musculoskeletal tumors, please visit my website at www.tumorsurgery.org. These are your most common types of soft tissue sarcomas, or your most common type of malignant soft tissue tumors. MFH, also called UPS, malignant fibrous histiocytoma, or undifferentiated pleomorphic sarcoma, is believed to be the most common soft tissue sarcoma. Liposarcoma is the second most common, although there is a debate, an ongoing debate as to which one is more common, liposarcoma or MFH. Leiomyosarcoma is your third most common type of soft tissue sarcoma, followed by synovial sarcoma. If we're considering just the extremities, probably synovial sarcoma is your third most common soft tissue sarcoma of the extremities. Leiomyosarcoma has a higher predilection for the retroperitoneal or the retroperitoneum. Fibrosarcoma, rhabdomyosarcoma, epithelioid sarcoma. Epithelioid sarcoma is the most common soft tissue sarcoma of the hand. Malignant peripheral nerve sheath tumor, also called MPNST. Extraskeletal osteosarcoma, Ewing sarcoma, and chondrosarcoma. Even though osteosarcoma, Ewing sarcoma, and chondrosarcoma occur more commonly from the bone, there are extraskeletal or soft tissue variants which are much less common than their bony counterparts. All soft tissue sarcomas primarily affect adults 40 to 70 years of age, except for rhabdomyosarcoma, which primarily affects children up to the age of 20, and synovial sarcoma, which tends to affect young adults and teenagers from the ages of 15 to 35 years of age. Although, of course, there are outliers with each type of sarcoma. Soft tissue sarcomas are usually painless. They're a painless mass, except synovial sarcoma. 50% of synovial sarcoma cases may cause pain, but most soft tissue sarcomas are painless, which is somewhat counterintuitive to think that a cancerous tumor does not cause pain. Pain is usually more indicative of a benign mass. Hemangiomas, fibromatosis, schwannoma, angiolipomas, they all tend to be at least mildly painful. The MRI appearance of a sarcoma is nonspecific. It usually presents as a nonspecific heterogeneous soft tissue mass on T1 and T2 weighted images. And the reason why it's heterogeneous is that the majority are high grade and they have necrosis and hemorrhage within them, which causes a varying appearance in different areas of the mass. Well-differentiated liposarcomas and myxoid sarcomas, namely myxoid liposarcoma and myxoid MFH, tend to have a more uniform appearance on an MRI. Well-differentiated liposarcomas follows fat on all sequences, and myxoid tumors tend to be fairly homogeneous on your T2 weighted images, showing very high signal. There's a lot of fluid content in myxoid tumors. Myxoid tumors produce mucin or mucus, which contains mucopolysaccharides, which entraps water, and that shows up as a very high diffuse signal on the T2 weighted images. On a T1 weighted image, it usually resembles muscle, or maybe lower signal than muscle. And it's important to note that these tumors, the myxoid tumors, can be misconstrued as cysts or ganglion cysts, depending upon where they're located, because of their myxoid nature and the fluid content within them. Very important to administer gadolinium. Myxoid tumors will enhance with gadolinium. A ganglion cyst should not have any internal enhancement. In terms of calcification and mineralization, really any sarcoma can calcify, but some tumors are more well known for having calcifications deposited in them. Synovial sarcoma is notorious for calcification. Extraskeletal chondrosarcoma and osteosarcoma may demonstrate mineralization. Lipomas or liposarcomas that have undergone necrosis can have calcium deposited in them. Hemangiomas, usually they're a benign soft tissue tumor, but they may have phleboliths within them, which is a form of calcification. And synovial chondromatosis. Sarcomas, since they're cancerous, they metastasize, and usually always the lungs is the first site of metastases, followed by the bones, then the liver. So the three most common sites are lungs, bones, and liver. Myxoid liposarcomas metastasize to other soft tissues and bones. Okay, so that can have a very strange pattern of metastasis. It can also metastasize to the spine. These are your three most common soft tissue sarcomas to metastasize to lymph nodes: synovial sarcoma, epithelioid sarcoma, and rhabdomyosarcoma. Sentinel lymph node biopsies for patients who do not have any florid lymph node metastases may be necessary for these types of tumors. Okay, so where are the most common sites for sarcomas? The thigh is the most common site for malignant fibrous histiocytoma, fibrosarcoma, and liposarcoma. And when you think about it, it's the area of your body that has the most amount of soft tissue. Fibromatosis is common around the shoulder girdle. Synovial sarcoma usually occurs around, but not usually within a major joint. So synovial sarcoma, the name of it is a misnomer. It does not mean that it comes from the synovium. Pathologists gave it this name because of the two cell types typical of a synovial sarcoma that in their mind resembled synovial tissue, and that's how it got its name, but it rarely ever occurs in a joint. In terms of the foot and ankle, synovial sarcoma is the most common soft tissue sarcoma in the foot and ankle. And in the hand, epithelioid sarcoma is the most common soft tissue sarcoma, which often ulcerates. In the retroperitoneum, liposarcoma and leiomyosarcoma are the most common soft tissue sarcomas. Some sarcomas may have adjacent osseous involvement. They occur next to the bone. MFH, synovial sarcoma, and rhabdomyosarcoma are the most common sarcomas to either erode the adjacent bone or develop a metastasis, sort of a regional metastasis to the adjacent bone. Rhabdomyosarcoma can also metastasize to the bone marrow. Therefore, in evaluating this type of patient, it's important to do a bone marrow aspirate. These are your important translocations that you should know. Synovial sarcoma has a TX18, which results in a fusion protein SYT-SSX. Myxoid and round cell liposarcoma, which are your two types of liposarcomas, have a T12-16 translocation. Okay, your different types of liposarcomas are well-differentiated liposarcoma, myxoid liposarcoma, round cell liposarcoma, and pleomorphic liposarcoma. And there seems to be a spectrum between myxoid and round cell, and they tend to have the same chromosomal translocation. Alveolar rhabdomyosarcoma has T213, which is the PAX3/FKHR transcript, and T113, the PAX7/FKHR chimeric protein. Okay, all soft tissue sarcomas are spindle cell tumors except for the following. Synovial sarcomas can be biphasic, meaning that they have a spindle cell component and as well as an epithelioid component. That's important because what identifies immunohistochemically as a sarcoma is the presence of vimentin, and usually keratin or epithelial membrane antigens signify a tumor that's a carcinoma, like a lung cancer, breast cancer, kidney cancer, thyroid cancer. However, there are certain tumors that can express both elements, and a biphasic synovial sarcoma can be vimentin positive as well as epithelial membrane and keratin positive because it has epithelioid elements. Likewise, epithelioid sarcoma can express both vimentin and keratin, and they have epithelioid or polygonal type cells. Rhabdomyosarcoma is technically considered a small round blue cell tumor similar to Ewing sarcoma, and you can see rhabdomyoblasts in a rhabdomyosarcoma. And extraskeletal Ewing sarcoma is a small round blue cell tumor. It's not a spindle cell tumor. These are your important immunohistochemical stains. Vimentin. All sarcomas are vimentin positive. Cytokeratin. All carcinomas are cytokeratin positive. Synovial sarcoma is vimentin, cytokeratin positive, and epithelial membrane antigen positive. Epithelioid sarcoma is vimentin positive, cytokeratin positive, and epithelial membrane antigen positive. Malignant peripheral nerve sheath tumors demonstrate diffuse S100 positivity, may occur in the setting of neurofibromatosis and their nerve in origin. Leiomyosarcomas are strong actin positivity and also demonstrate some desmin positivity. Rhabdomyosarcomas demonstrate very strong desmin positivity, lesser actin positivity. They're positive for MyoD1 and myoglobin. You can also see the translocation. It occurs in a younger age group. You see rhabdomyoblasts, which are characterized by their cross striations similar to skeletal muscle. MFH and fibrosarcoma have no special differentiation. They're vimentin positive only. Sometimes there are myofibroblasts in MFH, which may show scant and scattered actin positivity. But by and large, these are primarily vimentin positive with no other markers. Most high-grade sarcomas of an extremity present as tumors that are greater than 5 centimeters in diameter, deep to the fascia, and without the presence of overt metastases. This is important. This is a stage 3 tumor according to the AJC classification. Stage 4 tumor is any high-grade sarcoma with metastases anywhere. The general treatment plan for soft tissue sarcomas are wide excision and radiation, or limb-sparing surgery followed by radiation. Chemotherapy may be considered for rhabdomyosarcoma in children and synovial sarcomas in young age groups. And in general, though, it's very controversial to give chemotherapy for other types of high-grade soft tissue sarcomas. I think at most a 10 to 15% benefit has been shown in terms of survival. So it is somewhat controversial. So the treatment answer for your OITE is wide excision and radiation, except if it's an enormous tumor which is encasing the neurovascular structures, or it's fungating and infected, or the entire extremity has been contaminated by a biopsy, then you may answer amputation. This is very general survival data. In general, there's a 60 to 65% 5-year survival from non-metastatic soft tissue sarcomas. There's a 15% 5-year survival for patients with resectable mets to the lungs. So if a patient presents with metastases to the lungs, there's a 15% chance of them surviving 5 years, provided the mets can be resected. And if they do not present with metastases, they're non-metastatic at initiation, there's a 60 to 65% overall 5-year survival. Liposarcoma. Liposarcoma is considered the second most common soft tissue sarcoma after malignant fibrous histiocytoma, or UPS, undifferentiated pleomorphic sarcoma. It's usually an adult tumor, occurs in 40 to 70 years of age. It's extremely rare in children and adolescents. It involves usually the thigh is the most common site, followed by the retroperitoneum and the trunk. There are different types of liposarcomas. Well-differentiated liposarcoma, also referred to as low-grade liposarcoma or atypical lipoma. It could have a very similar appearance as a as a lipoma, a very large lipoma on an MRI. It follows fat signal intensity on all sequences. Myxoid liposarcoma, which has a high fluid content because of the mucinous material, looks much different on an MRI, and you may not be able to identify fat within the actual tumor on the MRI. Then there's round cell, poorly differentiated hypercellular tumor, and pleomorphic liposarcoma. And as we're going from low grade or well differentiated to pleomorphic, these become higher in grade, with pleomorphic being the most aggressive tumor. There seems to be a transition between myxoid and round cell, and they have the same chromosomal translocation. Histologically, you can identify fat within all these tumors, but it can take a very experienced radiologist to detect fat on an MRI of these tumors. The round cell and pleomorphic look like heterogeneous masses, whereas the myxoid tumors look like more of a homogeneous intermediate to low signal on T1 and high signal on T2. Then there's a dedifferentiated form of liposarcoma, where a well-differentiated liposarcoma seems to have undergone an area of dedifferentiation, or where portions of the tumor in different areas have taken on characteristics of a poorly differentiated sarcoma. Okay, and this poorly differentiated area is the area that can metastasize. While it is more aggressive than a low-grade tumor, it tends not to be as aggressive as a pleomorphic liposarcoma. Liposarcomas are more commonly to occur in an intermuscular or between the muscle location. And when you think of it, that's where the majority of fat exists, is in between the muscles of the extremities. The more differentiated the lesion, the more fat it will appear to have on an MRI. Well-differentiated liposarcoma may have large adipose-containing regions and thickened nodular septations on the MRI. And it's these thickened nodular septations that may help you separate this from a large lipoma. Fat is more difficult to identify within the other variants, but small scant amount of fat may be present on various MRI images, but it can be very difficult to discern. It needs standard T1, T2, and T2 fat suppressed images. Myxoid liposarcoma is more homogeneous, and the majority of the lesion follows fluid signal intensity on all sequences. Myxoid liposarcoma can be misinterpreted as a cyst. Round cell pleomorphic liposarcomas are more heterogeneous in nature on an MRI. And for dedifferentiated liposarcoma, you look for focal nodular areas of soft tissue within an otherwise well-defined fatty mass. So you can see the majority of the mass may appear to be normal fat on an MRI, but you have these focal nodular areas which look different. First entity we'll talk about is a low-grade, well-differentiated liposarcoma, also called an atypical lipoma. And this consists of mature fat cells and almost always fibrous or myxoid tissue. It's characterized by the presence of lipoblasts. Lipoblasts are not present in a lipoma. Lipoblasts are adipocytes that have enlarged irregular hyperchromatic nuclei. They're primitive fat cells, and these can be scattered throughout the tumor. This is a low-grade malignant tumor, meaning it's slow growing, and it does not usually ever metastasize. It does have a potential, though, to dedifferentiate into a high-grade tumor that can metastasize. So they're removed for multiple purposes. The tumors can continue to grow, and they can dedifferentiate into a higher-grade tumor. Nobody knows the exact percentage of them that will dedifferentiate, and usually the dedifferentiated tumors are not picked up until after the tumor's actually changed. And it has a higher potential for local recurrence than a lipoma. This is showing you a typical lipoblast. Okay, a normal fat cell will have the nucleus compressed up against the periphery, and it makes it look like a thin or thickened slit in the cell membrane. This is the vacuole that contains the fat, and then you have this more stellate type irregular nucleus in the center of the cell that usually has this chromatin that streaks outward from it, and that's very characteristic of a lipoblast that you need to recognize to characterize something as a low-grade liposarcoma or any of the other liposarcomas. Low-grade liposarcomas usually affect adults, middle-aged to older adults. They're usually intramuscular. The thigh, the arm, the buttock, the retroperitoneum are common sites, and a subcutaneous location is extremely rare. A fatty tumor in a subcutaneous location is almost always a lipoma. Well-differentiated liposarcomas are usually painless. They don't cause pain. They're soft to firm depending on the amount of fibrous tissue. They can grow very large, and the tumors in the retroperitoneum can present with abdominal swelling. Okay, how do you tell the difference between a lipoma versus a well-differentiated liposarcoma on an MRI? Well, truth be told, you can't really tell 100% unless it's removed and it's biopsied and analyzed histologically. However, thickened septae on an MRI is more suggestive of a well-differentiated liposarcoma. Nodular, irregular globular areas of non-adipose tissue, again, more suggestive of a well-differentiated liposarcoma. If there's an associated non-adipose mass, the total amount of non-adipose tissue is greater than 25%. If there's marked enhancement of these stranding areas or the non-adipose areas, and an older patient or a larger size mass, all these are suggestive of a well-differentiated liposarcoma as opposed to a lipoma. CT scan of a well-differentiated liposarcoma usually shows a non-specific soft tissue mass with fat and soft tissue elements. It may enhance with contrast. Lipomas do not enhance. MRI demonstrates predominantly fat in all sequences with irregularly thickened linear or nodular septa. The septa are low signal on T1, similar to muscle, and high signal on T2. This is showing you an MRI of a low-grade or well-differentiated liposarcoma. This is a T1 weighted image and T2 weighted image. You can see a very large intramuscular mass, has signal intensity similar to fat on both the T1 and the T2 weighted fat suppressed images, and you have these thickened septae throughout the mass, which are more consistent with a low-grade liposarcoma. These septae sometimes are high signal on the T2 weighted image. This is an axial section of a low-grade liposarcoma. Again, notice the stranding in the mass. Large size, stranding in the mass, and the stranding is higher signal in the T2 weighted image. This is the gross pathology. You see some muscle was taken out with this tumor. Very large mass, nodular, looks fatty in nature. This is a well-differentiated liposarcoma of the calf without much stranding within it. Again, the majority of the mass suppresses on the T2 weighted image, indicative of fat. Again, gross specimens of well-differentiated liposarcomas. You should see yellow, mature-appearing fat mixed with fibrous and myxoid tissue. And this is a higher power view or a close-up, and just fatty tissue. Can be infiltrative into the muscle. Microscopic pathology of a low-grade liposarcoma, you have to look for a lipoblast or lipoblasts within it. Scattered fat cells with irregular dense nuclei and often multiple cytoplasmic fat vacuoles. So it may not be a single vacuole, but multiple. You'll have adult mature fat cells of variable sizes, whereas a lipoma you tend to have fat vacuoles of similar size. There's variable amounts of fibrous and or myxoid tissue with scattered cells with irregular nuclei, and rare mitoses may be enlarged and atypical. And you see here, you can see here that these are the fat cells, and you have these thickened fibrous areas also that may be, you need a higher power view, but may be indicative of a low-grade liposarcoma. Again, another low power view of a well-differentiated liposarcoma. perhaps you can see here on a low power view the presence of a lipoblast. These are what the mature fat cells look like, although these nuclei are a bit large. Usually they're very slit-like for mature fat cells. These are fairly large and are more consistent with lipoblasts. Okay, something like this in this location here, this nucleus is more consistent with a mature fat cell. This is more consistent with a lipoblast. The treatment for any type of sarcoma, you don't answer marginal excision for your OITE exam. You answer wide surgical excision. So the mainstay of treatment for this tumor is wide surgical excision. Nobody really knows if radiation is effective at controlling local recurrence, but to give a person radiation, you have to weigh the risks and benefits of everything. So in this instance, if this tumor were to recur in, say, the thigh, it's probably less morbidity to observe it and remove it again as opposed to give radiation. These tumors do not metastasize as 100% 5-year survival. Recurrence occurs 10 to 20% of the time, particularly with intramuscular tumors. Naturally, the recurrence depends on the size of the tumor and the location. It may take years to recur and to grow to a sufficient size. Dedifferentiation seems to be a rare event, but can occur with recurrences. And MFH is the most common dedifferentiated component of a dedifferentiated liposarcoma. Okay, myxoid liposarcoma is the next entity we will speak about, and this is a variably cellular fatty tumor that contains small, uniform, signet ring lipogenic tumor cells in a myxoid matrix. The amount of adipose tissue may be scant. It also contains small, uniform, non-fatty cells with scant cytoplasm and arborizing capillaries. Myxoid liposarcoma and round cell liposarcoma are a spectrum of the same type of tumor. Round cell liposarcoma is more cellular, and it's a more cellular variant of the myxoid. They have the same chromosomal translocation T12, 16, Q13, P11. Round cell liposarcoma is high grade and has greater metastatic potential. Myxoid liposarcomas can have round cell components. If greater than 25%, has a higher metastatic potential and technically is considered a round cell liposarcoma. Myxoid liposarcomas are technically considered an intermediate grade tumor. They metastasize about 30 to 35% of the time. They also may have strange areas of metastases, particularly to the spine or other soft tissues, not necessarily directly to the lungs. Myxoid liposarcomas constitute 40 to 55% of liposarcomas. They usually occur in the 40 to 50 year age group, rarely in a patient less than 20 years of age. Most common sites are the deep soft tissues. They are very rare to occur in the subcutaneous tissue, as opposed to malignant fibrous histiocytoma, which can occur in the subcutaneous tissue. Most common sites are the thigh, the buttock, the groin, the popliteal space. It's unusual for a myxoid liposarcoma to occur in the retroperitoneum. Clinically, patients present with a painless mass, just like other types of sarcomas. On an MRI, a myxoid liposarcoma does not contain substantial amounts of fat. Maybe you can detect it 30% of the time if you're a really good radiologist. It follows fluid signal on an MRI. The T1, you have an intermediate signal similar to muscle. You may see some high signal areas indicative of fat. On the T2, you have all high signal. On the fat suppressed images, high signal areas on the T1 may suppress if they are fat. And the fat, if it's detectable, usually is lace-like or wispy or cloudy. It's amorphous or clump-like. These can often be misdiagnosed as a ganglion cyst. Here's an example of a myxoid liposarcoma of the buttock. An intramuscular tumor, this is the T1. It's low signal or similar to muscle on the T1, and you can see very high signal on the T2 because of the myxoid or mucinous fluid component. Again, T1 weighted image up here in the right hand corner and T2 in the lower left hand corner. This looks like it occurred in the neck and low to intermediate signal on T1 with some high signals areas within it that may be indicative of fat. And you can see on the T2 fat suppressed, these high signal areas suppress out and become dark, so that may be indicative of cloudy wisp-like fatty tissue within it. But the majority of the mass is very high signal because of the mucinous component. This is that same image in the neck area. Here's a myxoid liposarcoma of the thigh, very large intramuscular or perhaps intramuscular mass from the vastus intermedius. You can see some wispy high signal areas on the T1. The majority of the mass is similar to muscle intensity on the T1, and then very high signal on the T2 weighted images with perhaps some wispy dark areas that may correlate with wispy bright areas on the T1. But again, this would take an experienced radiologist to really identify that as fat, and certainly there's a differential of this from a myxoid liposarcoma to a myxoid MFH. It would need to undergo a biopsy. Here's a myxoid liposarcoma of the elbow area involving the brachialis muscle. This was thought to be a ganglion cyst, and attempted aspiration was made a few times without success. This is a T1 weighted image and T2 weighted images, sagittal and axial sections. And you can see here sort of an oblong mass following the brachialis muscle, similar signal intensity to the muscle on the T1, and very high signal on the T2. And because it was adjacent to the joint and had this little teardrop shape to it, it was thought that this was probably a ganglion cyst communicating with the joint. The differential diagnosis of myxoid soft tissue tumors includes myxoid MFH, myxoid liposarcoma, neurogenic tumors, schwannoma, malignant peripheral nerve sheath tumors, myxoma, which is a benign soft tissue mass, Ewing's extraskeletal myxoid chondrosarcoma, okay, and leiomyosarcoma. This is the gross pathology of a myxoid liposarcoma, and you can see where it has a slimy, gelatinous, mucus-like surface. Clear round cell areas have a fleshy sarcoma appearance, which may be a little bit difficult to discern from this photograph. A microscopic pathology of a myxoid liposarcoma, you're looking for small uniform cells with scant cytoplasm in a myxoid matrix. Looking for signet ring lipoblasts. The nucleus is deformed into a crescent. Scattered adipocytes of various sizes, few mitoses, and the round cell areas are the more cellular areas, more mitoses, more pleomorphism, but there's usually not marked pleomorphism. This is showing you an intermediate power view of a myxoid liposarcoma, and you can see here the signet ring lipoblasts, right, the fat cells, so you can immediately identify this as a fatty type of tumor. And then this is all the myxoid or mucinous type tissue with the small cells within it, or the little round cells, and then arborizing capillaries. Higher power view, again, the wispy myxoid tissue. You have to recognize this as myxoid type tissue. Usually stains a pale blue because of the mucus type of material or the mucopolysaccharides, and all the signet ring lipoblasts. Much different than a low-grade liposarcoma where you would see this filled with vacuoles. And here to note, remember, malignancy is suggested by different sizes and shapes of the vacuoles. Again, another type of myxoid liposarcoma where you can see the large vacuoles here, and this is a particular myxoid / round cell area. And this is a high power view of a signet ring cell lipoblast. and the mucinous material in between all these small round cells. Again, a very classic example of a myxoid liposarcoma. You can see all this blue staining matrix in between all these fatty vacuoles. The vacuoles are different sizes and shape, and the cells, there's not marked pleomorphism between all the cells. There's not a lot of mitotic figures, but it's producing this bluish mucinous type of material. And this is a very heavily mucinous area within the tumor. Again, the bluish staining. Remember, fibrous tissue stains pink because of the collagen. The mucopolysaccharides stain blue, or sugar entities stain blue, and this traps water, which shows up as a high signal intensity on the T2 weighted image. Okay, treatment for a myxoid liposarcoma. The mainstay of treatment is wide resection and postoperative radiation. Okay, there's a high rate of local recurrence without radiation, so usually these are treated or also given radiation. Some of it depends upon the size of the tumor and the extent of the margin, but the OITE answer would probably be wide resection and postoperative radiation. Myxoid liposarcoma is a low to intermediate grade tumor by virtue of its name. Unless it has greater than a 25% round cell component, then technically it falls into the category of a round cell liposarcoma, which has a much higher metastatic rate and is a higher grade tumor. There's an 88% 5-year survival for a pure myxoid liposarcoma. The rate of metastasis is related to the proportion of round cell component, and there may be an unusual pattern of metastases. Sometimes it metastasizes to the retroperitoneum and the mediastinum, to the spine. I've seen metastases to the heart, actually, and as well as to the brachial plexus. So the patient needs to be monitored closely. Next entity we'll discuss is malignant fibrous histiocytoma. Malignant fibrous histiocytoma is a pleomorphic high-grade anaplastic sarcoma composed of varying proportions of fibroblasts, myofibroblasts, histiocyte-like cells, but not true histiocytes, multinucleated cells, and undifferentiated cells. So it's very pleomorphic. It's called an undifferentiated pleomorphic sarcoma. That's the more common term used today. It may have substantial myxoid components, inflammatory tissue, and giant cell rich areas. There's no recognizable line of differentiation, such as smooth muscle, skeletal muscle, bone, cartilage, or fatty differentiation. And it stains vimentin positive and not for any other markers. Occasionally it may stain slightly for actin because of the myofibroblasts. MFH is considered the most common soft tissue sarcoma. 70 to 75% occur in the extremities and 15% in the retroperitoneum. It's the most common post-radiation sarcoma. It can also occur at the site of chronic ulcers and scars. It has been associated with chronic indwelling shrapnel and total joint replacements, and there are multiple subtypes, namely pleomorphic, myxoid, giant cell variant, and inflammatory, according to the percentage of these other cell types that you can see within it. Usually patients are greater than the age of 50. It's rare in children. It usually affects the deep soft tissues and arises from an intramuscular location, namely the thigh, the buttock, the retroperitoneum, the shoulder girdle, the calf, the trunk are the most common sites. It can also occur subcutaneously. It's one of the more common subcutaneous sarcomas. MFH usually presents as a painless mass. Rarely a patient may have a fever and weight loss, but that's very unusual. And occasionally a patient may have leukocytosis, hypoglycemia, and systemic manifestations. Okay. The radiological characteristics of a malignant fibrous histiocytoma. An MFH usually presents as a deep intramuscular mass as opposed to an intermuscular mass, often adjacent to the diaphysis of long bones. Osseous involvement can occur, which is detectable on an X-ray or a CT, and you can have direct invasion or you can have a skip metastasis into the adjacent bone. MRI is very nonspecific. However, it usually shows a heterogeneous mass on both T1 and T2 weighted images because there's significant hemorrhage and necrosis within this rapidly growing high-grade malignancy. It's usually a large tumor, lobulated, and appears to be well defined because the tumor itself is compressing the adjacent muscles into a pseudocapsular layer, although this pseudocapsular layer actually contains tumor within it. The tumor may be intermediate on T1 and predominantly high signal on T2, but again heterogeneous on both. And the viable areas of the tumor enhance with contrast. Necrotic areas will not enhance with contrast. This is important when determining biopsy because a biopsy will be directed at the viable areas that enhance with contrast. MFH can look very well circumscribed on a MRI. There is a peripheral pseudocapsular where the muscle layers are compressed, and it gives the tumor a very round or well circumscribed appearance, but this is very misleading because it is not really a well circumscribed tumor. The tumor will infiltrate into this pseudocapsular layer, and that pseudocapsular layer will be involved by neoplasm. It needs to be removed at the time of surgery. Myxoid variants of MFH are very high signal on T2 weighted images and can look very uniform. Myxoid variant may show peripheral and septal or diffuse enhancement, and that's very useful for differentiating it from a ganglion cyst, which can have a very similar radiological appearance on an MRI, where it's intermediate to low on T1 and very high signal on T2 and very uniform appearance on T2 because of the mucopolysaccharides that entrap the water. So having enhancement of the mass helps differentiate the neoplasm from an actual cyst or ganglion cyst. And also for myxoid variants of any type of tumor, you want to look for any fat on the MRI, presence of fat, to rule out a liposarcoma or a myxoid liposarcoma. Again, only about 30% of the time can fat be identified on an MRI by a very experienced radiologist. This is an MRI of an MFH of the thigh, and what we see here is a T1 weighted image and a T2 weighted image. This is your femur, and here is a large mass developing from the posterior compartment of the thigh. It's growing in a ball-like manner. It's compressing the adjacent muscles into a pseudocapsular layer. The mass is heterogeneous on the T1 weighted image and heterogeneous on the T2 weighted image. You can see on the T1 the majority of the mass is similar signal intensity as muscle, or intermediate signal intensity, with a dark area in the center. This dark area is very bright on the T2 weighted image, indicative of hemorrhage and necrosis. The mass on the T2 weighted image is primarily heterogeneous, well, primarily high signal but heterogeneous. And remember, these masses grow rapidly. Areas of them can infarct. They outgrow their blood supply. Areas will infarct, undergo necrosis, and hemorrhage into the area, and it gives you this appearance on an MRI. Now, with that said, the MRI appearance of an MFH is nonspecific. There are many high-grade sarcomas that can have a similar appearance. I can tell you that this is a pleomorphic liposarcoma. I can tell you that it's a leiomyosarcoma, a fibrosarcoma, a synovial sarcoma. They can have a similar appearance, and a biopsy is really required to differentiate these entities. Again, an MFH with a significant area of necrosis within it. This is an MFH of the foot, a very unusual site, but again a heterogeneous mass on this T1 weighted image and a T2 weighted image. And this is the MFH of the foot, heterogeneous, have both high and low signal areas. Here's an MFH of the thigh along the adductor compartment. Very heterogeneous, large soft tissue mass with both high signal areas and intermediate signal areas similar to muscle. This is the T2 weighted image of that same MFH of the thigh. And again, you see mixture of signals, intermediate low, intermediate, and high signals. These high signals probably are more indicative of hemorrhage and necrosis, which goes along with the high-grade nature or the rapidly growing mass, where the blood supply gets cut off and the mass hemorrhages into itself. This is the CAT scan of the MFH of the thigh. Again, there's no underlying bony erosion with this tumor, but CAT scans may be useful for detecting that. And you see a large mass here with different attenuations, but these areas are probably areas where it's undergone necrosis and hemorrhage, similar to what you see on the actual MRI. Here's a subcutaneous MFH of the thigh, a very firm mass in the thigh, and this is a T2 weighted image. Again, heterogeneous, but you can see the deep tumors tend to obey fascial borders, whereas when an MFH occurs in the skin, you could see where there's these strands that extend for a far distance out from the sides of the mass. Okay, in order to remove this, you need to remove a significant portion of the skin and the underlying fascia, and perhaps a sliver of the muscle. Here's the same tumor in MRI with gadolinium, and you can see how the gadolinium enhances the mass. Okay, let's talk about the pathology of an MFH. Grossly, it's a fleshy, multilobulated tumor with areas of hemorrhage and necrosis. And you can see here, these are the areas over here of hemorrhage and necrosis, which is indicative of malignancy, and the very fleshy areas here. Sarcoma gets its name from Greek language and indicating fleshy or fish flesh type of appearance. Microscopically, an MFH has bizarre pleomorphic spindle cells, large irregular bizarre nuclei, fibroblasts, myofibroblasts, undifferentiated cells, and histiocyte-like cells, but no true histiocytes, fibrous tissue stroma or matrix, extensive pleomorphism, abundant atypical mitotic figures, and characteristically, the fibers are arranged in a storiform pattern of arrangement of cells and matrix, or a swirling pattern of collagen bundles and cells. This is showing you a very characteristic slide of an MFH, and you can see here the swirling pattern of the cells and the fibers. You have a very pleomorphic tumor. The cells are crowded on each other. They're all arranged haphazardly. There's some large cells, some small cells, some intermediate cells, some bizarre giant cells, a lot of mitotic figures and atypical mitotic figures, and it's producing fibrous type tissue. Hey, this is a storiform pattern as opposed to a classic fibrosarcoma, which usually has a herringbone pattern. Again, another example of microscopic view, intermediate level of an MFH. And again, a fibrous tumor with a lot of bizarre appearing cells and cells at different sizes and shape. Very high-grade anaplastic tumor. Again, MFH, again, showing you bizarre cells and this swirling pattern of the fibrous tissue. Large giant cells, dark hyperchromatic nuclei, crowded cells, cells arranged haphazardly. Okay, in terms of treatment of an MFH, treatment entails surgery. Surgery is the mainstay of treatment, and wide surgical resection is indicated. Since this is a sarcoma, if you're going to perform a limb-sparing surgery, it's a wide surgical resection followed by radiation. Now, it is controversial as to whether or not you can give preoperative or postoperative radiation. The answer for your OITE and the boards will be wide surgical resection and radiation. I don't think they will ask you to differentiate between preoperative and postoperative radiation, and there are advantages and disadvantages of giving radiation preoperatively and or postoperatively. So you try to perform a limb-sparing resection whenever feasible, and amputation is usually reserved for unresectable cases. Tumors that may be wrapped around the neurovascular bundle or may have recurred despite giving radiation, or a tumor that may be infected and fungating, or perhaps an inappropriately placed biopsy was performed and there was hemorrhage and contamination of the entire thigh or extremity. In these cases, an amputation may be considered or may be indicated. Metastases occur in up to 45 to 50% of patients with MFH. The most common site of metastatic disease is the lung, followed by the bone, the liver, and the lymph nodes. Synovial sarcoma and rhabdomyosarcoma and epithelioid sarcoma metastasize to lymph nodes much more often than MFH. Overall, there is a 65% 5-year survival rate with an MFH. However, there is a significant drop-off between 5 and 10 years where there's approximately a 50% 10-year survival rate for patients afflicted with a non-metastatic MFH at presentation. Patients who present with overt metastases, in general, there's about a 15% 5-year survival rate. The next entity that we're going to speak about is fibrosarcoma. Okay, many experts believe that a high-grade fibrosarcoma is an MFH, or really an MFH is really a high-grade fibrosarcoma, since neither tumor shows any specific evidence of differentiation other than expressing vimentin. But let's consider fibrosarcoma as a separate entity, and a fibrosarcoma is a malignant tumor of fibroblasts that shows no other evidence of differentiation, meaning that it expresses vimentin only. It doesn't express smooth muscle markers or any other types of markers that would show that it's heading down the path of differentiating into some other type of tissue. The spindle cells are usually uniform and demonstrate minimal pleomorphism, meaning that the cells are similar sizes and shapes. It's a rare type of soft tissue sarcoma. It constitutes 5% of all soft tissue sarcomas, and it occurs in the 40 to 5-year age group. There is an infantile form in the less than 10-year age group. And the sites where it occurs primarily intramuscular and rarely in the subcutaneous tissue. The most common sites are the thigh, the knee, the buttock, the arm and the shoulder girdle, the trunk, the forearms, and the legs. Clinically, patients present with a painless mass. It is usually not painful. It's painless. And usually fibrosarcomas are graded as grade 1, grade 2, grade 3, meaning grade 1 is low grade, slow growing, rarely metastasized. Grade 2, intermediate grade, and grade 3 are rapidly dividing, faster growing masses, may have more pleomorphism, more mitotic figures, and have a higher rate of metastatic disease. There can be fibrosarcomas can arise from secondarily from other causes or from specific other disease processes. Irradiated soft tissues can be a source of fibrosarcoma. Scars and burns can be a source of fibrosarcoma development. It can be a dedifferentiated component of a dermatofibrosarcoma protuberans and a dedifferentiated component of a liposarcoma. The overall 5-year survival of a fibrosarcoma is 40%. It's got a greater than 60% metastatic rate, and it's virtually indistinguishable from a malignant fibrous histiocytoma on imaging. 2/3 of fibrosarcomas are intramuscular, and they appear to be a well-defined heterogeneous mass. They grow like a ball. Necrosis and hemorrhage are common, especially in higher grade tumors, and viable areas enhance with contrast similar to an MFH. Areas of significant necrosis and hemorrhage do not enhance, and that's similar in an MFH, similar in a pleomorphic liposarcoma or a round cell liposarcoma. This is showing you an example of a fibrosarcoma. Deep tissue, thigh, this is a T1 weighted image, this is a T2 weighted image. Low to intermediate signal on T1 and heterogeneous on T2 weighted image. Another example of the MFH, of a fibrosarcoma, that is. Signal, it is a T1 weighted image where it's similar to muscle signal intensity and somewhat heterogeneous on the T2. This is showing you a CAT scan of the tumor where the tumor has similar attenuation as muscle. This is showing you a fibrosarcoma of the right buttock. T1 weighted images. Okay, similar in signal intensity to muscle. But you really can't say just based on this image that this is a fibrosarcoma. It could be an MFH, could be a Leiomyosarcoma, it could be pleomorphic liposarcoma, it could be round cell liposarcoma. This is the T2 weighted image, which shows you a heterogeneous mass. Okay, the high signal areas being necrosis and hemorrhage. Grossly, a fibrosarcoma is fleshy, just like other sarcomas, focally necrotic, and a hemorrhagic mass. It's firm and rubbery. Okay, the more firm and rubbery it is, usually the lower grade or well-differentiated collagenized, more collagenized it is. Higher grade tumors are more hemorrhagic and necrotic. Microscopically, you see elongated, fairly uniform spindle cells. They look like cigars with scant cytoplasm and large nuclei and a variable amount of fibrous stroma or fibrous matrix. There's minimal pleomorphism usually, particularly with grade 1 to grade 2 tumors. You see a herringbone pattern where the fibers are arranged in fascicles that intersect at right angles. And mitoses are present, also abnormal mitoses, and as you increase from a grade 2 to grade 3 tumor, the number of mitoses and abnormal mitoses increases, and that's partly how the tumor is graded. Okay, this is showing you the histology of a fibrosarcoma, and you can see here a classical herringbone pattern where some cells are cut longitudinally and others at a right angle or transversely, where you see their cross section. You usually have uniform spindle cells. You can see the cigar-shaped nuclei, minimal pleomorphism, and fibrous matrix. Really, many different types of sarcomas can have a similar appearance, such as a monophasic synovial sarcoma, a leiomyosarcoma. They can all appear similar, and you have to differentiate them sometimes with immunohistochemical stains. This is showing you the higher power view. Notice the cigar-shaped nuclei and the fibrous tissue. The nuclei are arranged haphazardly. They're crowded on top of each other. Hypercellular, some mitotic figures. Okay, over here, over here, over here. And some red blood cells. This is showing you the classic herringbone pattern with a fibrosarcoma. Okay, where some of the fibers are cut longitudinally and some in cross section. Differential diagnosis of a fibrosarcoma includes a monophasic synovial sarcoma. The synovial sarcomas are cytokeratin or EMA positive in addition to being vimentin positive. It also demonstrates a translocation of TX18 in 90% of cases. Leiomyosarcoma is stain positive for actin and desmin. Malignant peripheral nerve sheath tumors, which can have appearance similar to fibrosarcoma, are S100 positive, whereas fibrosarcoma is only vimentin positive. And fibromatosis can be differentiated from fibrosarcoma based on its morphological features and also perhaps on the MRI. Fibromatosis grows more in a more with finger-like projections at the periphery as opposed to a ball-like growth. Treatment for fibrosarcoma is wide surgical excision and radiation whenever feasible. There's always, with treatment of any sarcoma, there's always a controversy as to whether or not to give preoperative or postoperative radiation. So for the purposes of the boards or the OITE, they probably will not ask you about pre versus postoperative radiation. But the board answer is wide surgical excision and radiation, amputation for unresectable tumors. So for tumors which have recurred despite radiation, those that are encasing neurovascular structures, those which may be fungating and infected, or patients who have been treated with an inappropriately performed biopsy and their extremity has been contaminated. Metastases, the most common sites for metastases include the lungs, the bone, and the liver. And there's a 35 to 55% 5-year survival. The survival depends on grade, size, and location. Grade 1 tumors rarely metastasize, and grade 2 to 3 tumors metastasize more commonly in 35 to 45% of the time. So grade 1 tumors have a higher survival rate versus grade 2 to 3 tumors. Next, we'll turn our attention to talking about synovial sarcoma. Now, synovial sarcoma, remember, does not get its name because it comes from the synovium. It has an appearance histologically as being reminiscent of synovial tissue, given the fact that it usually has two cell types within it. So typically, synovial sarcoma is a biphasic soft tissue sarcoma with epithelial and spindle cell components. There is a monophasic variety in which the spindle cell only exists. It's not of synovial origin. It constitutes 5 to 10% of all soft tissue sarcomas. Primarily affects young adults and teenagers ages 15 to 35 years of age. It usually occurs in a deep location in close proximity to large joints, but not usually within the joints. The lower extremities are slightly more commonly affected than the upper extremity. The feet and hands may be affected. As a matter of fact, synovial sarcoma is the most common soft tissue sarcoma of the foot and ankle. May be intimately related to tendons, tendon sheaths, bursa, and muscles. It rarely occurs within an actual joint, less than 5% of the time, and if it does, the knee is the most common site. It's unusual in the retroperitoneum and in the head and the neck. The male to female ratio is 1.2 to 1, so almost equal amount of males and females are affected. It seems to have a predilection for Caucasian people as opposed to African American. Clinically, 50% of patients will have a painful mass. So this is one of the sarcomas which can be painful. The mass is usually slow growing, and it may grow over a period of 2 to 4 years. It may actually stay quiescent for a period of time and not grow. Patients will often complain of having a mass present for a couple of years which never changed. On the radiographs, calcification is present in 20% of cases, and there may be underlying bone invasion in up to 20% of cases. CT demonstrates a lobular mass close to a joint. The mass is usually heterogeneous and may have calcification and underlying bone erosion, and CT is useful for detecting subtle calcification. The MRI often shows hemorrhage, necrosis, and cystic change, which are common with this type of sarcoma, and it gives it a triple signal intensity, meaning that it has low, intermediate, and high signal areas on an MRI. MRI demonstrates a highly heterogeneous mass that enhances heterogeneously. Hemorrhage, necrosis, and cystic change are common. Synovial sarcomas also often grow in a lobular manner with internal septations. T1 weighted images demonstrate intermediate signal intensity similar to muscle. T2 demonstrates triple signal intensity, high, low, and intermediate signals consistent with the cystic formation, hemorrhage, solid elements, and fibrous tissue in the same tumor. Fluid levels indicative of hemorrhage or hemorrhagic areas may be present in up to 25% of patients. Okay, this is an example of an MRI of a synovial sarcoma of the shoulder, and you can see here where there's some underlying bony involvement of the proximal humerus. It's arising intramuscular deep to the deltoid. It's relatively intermediate signal intensity, similar to muscle. May be ill-defined or well-defined. It may have a pseudocapsule. There can be calcifications in 1/3 of cases. Lung metastases can also show calcification, and there's osseous involvement in about 20% of cases. This is the T2 weighted image of the synovial sarcoma where you see that triple signal intensity. You see here cystic change with hemorrhage and fluid levels, and both very low, intermediate, and high signal areas in the mass. Okay, it's very suggestive of a synovial sarcoma. Also, this lobular type of growth pattern. They often have septations in the middle, which almost make it look like a cluster of grapes, or make it look as though it's multilocular. This is the same synovial sarcoma with gadolinium administration, and you can see here where a significant component of the mass enhances, but then there's these large necrotic areas and cystic areas which are not enhancing, okay, which is typical, consistent with hemorrhage and necrosis. Here's the proximal humerus with the lesion in the proximal humerus, and you can see the fleshy tumor here on the gross specimen in the proximal humerus. the synovial sarcoma adjacent to the bone here in this location. This is an x-ray of a synovial sarcoma of the wrist area showing you calcifications. The calcifications can be stipuled or can be very dense, very suggestive of a synovial sarcoma. This is showing you that same tumor on an MRI. Intermediate signal on the T1 weighted image and high signal on the T2. This is an example of a synovial sarcoma of the leg that was initially thought to be a ganglion cyst because it arose adjacent to the tendons and it had many cystic changes within it on the T2 weighted MRI. But you can see these more fleshy areas which were very concerning. So this is T1 and T2 where you see the triple signal intensity, the very low, intermediate, and high signal areas. This is showing you the T1 and T2 weighted axial images of the leg of this synovial sarcoma. T1 intermediate and T2 low, intermediate, and high signal, growing in somewhat of a lobular manner. This is a synovial sarcoma adjacent to the knee with a very lobular growth. Certainly the lobular growth is not definitive for a synovial sarcoma. Naturally, a biopsy needs to be performed as well as immunohistochemical stains. There's the same MRI of the synovial sarcoma on both the T1 and T2 weighted images. This MRI of a synovial sarcoma of the leg. This is a very large synovial sarcoma where there was underlying bony invasion of the tibia. It's a T1 weighted image and T2 weighted images. Synovial sarcoma is one of the more common tumors that can invade the underlying bone or present with a skip metastasis to the adjacent bone. This is that same tumor in an axial section on the MRI, axial section of the leg, and you can see a very lobular pattern of growth with internal septations, cystic change with fluid levels, necrosis, hemorrhage, and almost a cluster of grapes appearance. This is a CAT scan of a synovial sarcoma of the leg, and you can see here the large mass, many cystic changes within it, and involvement of the underlying bone. You can't really detect much mineralization here on the CAT scan. Okay, what is the differential diagnosis of mineralization of a soft tissue mass? Okay, these are the tumors that more commonly mineralize or demonstrate calcifications. 1/3 of synovial sarcomas, MFH rarely does. Lipomas or a benign mesenchyma, particularly if they've undergone necrosis. Liposarcoma, there may be osseous and cartilaginous metaplasia, or liposarcomas that have undergone necrosis via injury. A malignant mesenchyma, hemangiomas, synovial chondromatosis, soft tissue metastases from a giant cell tumor or a soft tissue recurrence from a giant cell tumor. Tumoral calcinosis and gout can both demonstrate mineralization. Extraskeletal osteogenic sarcoma and extraskeletal chondrosarcoma. Melorhiastosis, which can present with a calcified soft tissue mass. Melorhiastosis is where you have what appears to be thickened candle wax drippings along the cortex or thickened undulated areas of the cortex, but these patients can also have adjacent soft tissue masses next to their joints. And a pilomatrixoma, which often occurs subcutaneously. Let's discuss the pathology of a synovial sarcoma. This is the gross pathology. Again, a yellow tan to gray mass that may be soft to firm depending upon the amount of cystic change, necrosis, and calcification, and tends to grow very lobular in nature with that internal stranding within it and almost a cluster of grapes appearance. Special studies that help confirm the diagnosis of a synovial sarcoma include the translocation TX18 demonstrating this, which results in the fusion protein SYT-SSX gene fusion transcript. This occurs in 90% of cases. Immunohistochemistry also helps you for both the biphasic and monophasic forms, where they are vimentin positive, and cytokeratin and EMA, epithelial membrane antigen positive. They're positive in both the biphasic and monophasic forms. In the biphasic form, you should be able to histologically see the epithelioid type cells in conjunction with the spindle cells. The spindle cell forms and the monophasic forms will demonstrate both markers also. In the biphasic form of synovial sarcoma, the spindle cells are intermingled with epithelial components that appear cuboidal or columnar in nature. The epithelial components form nests in glandular or tubular structures that may contain mucin within them. The monophasic form is a spindle cell component only. There are no epithelial components, and there is not a pure epithelial component or monophasic form. This is showing you a low power view of a synovial sarcoma. Again, you see a spindle cell tumor. This could be a fibrosarcoma. This could be an area of an MFH. It could be a leiomyosarcoma. Hard to tell really on this view, except that you want to look at these areas here where there are these glandular-like structures of epithelioid components. But the majority of the other areas show spindle cell components. But this is biphasic, and you have to notice these epithelioid components to classify it as an epithelioid, as a biphasic tumor. This is the spindle cell component of the synovial sarcoma. Again, cigar-shaped nuclei. The nuclei are crowded on top of each other. They may be hyperchromatic, minimal cytoplasm as opposed to large nuclei, and a fibrous type of matrix production. This is showing you a histological slide of a biphasic synovial sarcoma where you see the spindle cell component mixed with the epithelial component. It's very important to look at these slides very closely, particularly on your exams. So what you see here are the spindle cell component. You see these fibers and the spindle cells go in different directions with cigar-shaped nuclei, and then when cut transversely, the nuclei look much more circular in nature. And then over here you see the epithelial components where these epithelial-like cells are arranged in nests or in tubular structures reminiscent of glands or glandular type structures. Okay, so very important. This is a classical biphasic variety. Again, we'll stain positive for vimentin and positive for cytokeratin. This is a high power view of the synovial sarcoma. You can see this area here where it's the spindle cell area, and then the epithelial components or the more columnar or cuboidal components here admixed with the spindle cell components. Okay, you have to notice this on your OITE exam that this is a biphasic tumor. You see glandular-like structures or epithelial-like structures admixed with spindle cell areas. This is another very characteristic example of a synovial sarcoma with the spindle cell areas and the more glandular or epithelial component areas within it. Okay, biphasic synovial sarcoma. Another example, another histological example of a biphasic synovial sarcoma. You have to be able to identify these glandular-like structures. These are red blood cells. They might contain a mucin within them, which stains this pinkish color. But again, a spindle cell component with these glandular-like structures within them. Differential diagnosis of a synovial sarcoma includes a malignant peripheral nerve sheath tumor, fibrosarcoma, hemangiopericytoma, and a monophasic synovial sarcoma. Treatment and prognosis. The treatment for synovial sarcoma includes wide surgical resection and radiation. Again, postoperative or preoperative radiation is controversial, Amputation is utilized for unresectable tumors. Chemotherapy may be somewhat controversial, but in most children and adolescents, chemotherapy is indicated for the treatment of synovial sarcoma. This is one of the exceptions to the rule for treating soft tissue sarcomas, where chemotherapy has been shown to be effective in the adolescent and young adult age group. Okay, the most common sites of the metastatic disease include the lungs, the lymph nodes, and the bone marrow. Survival. Over 5-year survival is approximately 60 to 65%. 10-year survival approximately 35%. So there's a big drop off between 5 and 10 years. And there's a high incidence of late metastases that occur after the 5-year mark. Okay, Rhabdomyosarcoma is the next entity we're going to speak about, and that's the most common childhood soft tissue sarcoma. Rhabdomyosarcoma consists of malignant tumors composed of cells with light microscopic, electron microscopic, or immunological evidence of skeletal muscle differentiation. So this is a tumor or a malignancy that takes on skeletal muscle differentiation. Light microscopic features demonstrates usually rhabdomyoblasts, where there are these cells that appear like primitive muscle cells that have cross striations, similar to the cross striations seen in skeletal muscles. Ultrastructurally, you will see sarcomeres. Immunologically, they must express desmin, which is a skeletal muscle marker, myoglobin, MyoD1, and myogenin. You may have the presence of fusion genes PAX3-FKHR and PAX7-FKHR, which are specific for alveolar rhabdomyosarcoma. These are the different types of rhabdomyosarcomas: embryonal, alveolar, and pleomorphic. Embryonal is a small round blue cell tumor. It's the most common form. It occurs it represents 70 to 75% types of rhabdomyosarcoma. It occurs primarily in children. Alveolar demonstrates a solid and alveolar growth of cells. It represents 20 to 25% of all rhabdomyosarcomas, and it occurs primarily in children and adolescents. It has a worse prognosis than embryonal. Pleomorphic rhabdomyosarcoma demonstrates spindle cells and pleomorphic cells. It's very rare, less than 5% of rhabdomyosarcomas. Age is usually greater than 40 years of age, and it's a high-grade tumor. It has features similar to an MFH but stains for skeletal muscle markers. Rhabdomyosarcoma is the most common malignant soft tissue tumor in children. It represents 10% of all childhood neoplasms. Most commonly occurs in the first 2 decades of life, up to the age of 20. In terms of sites of involvement, embryonal is more common in the head and neck, and alveolar is more common in the extremities. The head and neck overall is the most common site, followed by the GU tract, the lower extremity and upper extremities, lower extremity being involved more often than the upper extremity, the retroperitoneum and pelvis, and then the trunk. Clinically, patients may have a painless or painful mass. Most commonly, it's a painless mass. It does not cause pain. There are no specific radiological features. It presents as a non-specific, usually heterogeneous mass. 24% of them invade adjacent bone. On MRI, demonstrates usually a heterogeneous mass. It does not follow signal intensity of skeletal muscle. On the T1 weighted image, it may be iso-intense to skeletal muscle. On the T2, it may be hyper-intense or high signal. It often demonstrates prominent vascularity, indicated by large flow voids with serpentine high-flow vessels. So you may see these very large vessels within these tumors. There's usually marked enhancement with gadolinium, and it may remain low to intermediate signal on T2 weighted images if there is extensive fibrous tissue within the tumor. This is an example of a rhabdomyosarcoma. You can see the patient is skeletally immature. This is in the thigh, and it's a non-specific heterogeneous mass. Okay, it may also spread to the adjacent lymph nodes. Showing you a very large mass in the thigh. Very heterogeneous. Okay, if you see this in a skelly immature patient, the first thought should be that this could be a rhabdomyosarcoma. This is showing you the gross pathology of a rhabdomyosarcoma. It's usually very fleshy, similar to other sarcomas, with there may be areas of hemorrhage and necrosis within it, similar to other high-grade sarcomas. Microscopically, embryonal rhabdomyosarcomas demonstrate small round blue cells. You may see rhabdomyoblasts, particularly tumors that are more well differentiated, and these rhabdomyoblasts are identified by identifying the cross striations within the cells, and they almost look like a little tadpole. They have a tadpole configuration or a tapering bipolar configuration. Alveolar rhabdomyosarcoma, the tumor cells grow in nests or clusters, at least focally, and you could also identify the rhabdomyoblasts with cross striations in an alveolar rhabdomyosarcoma. Immunohistochemically, rhabdomyosarcomas demonstrate desmin and actin positivity in greater than 90% of cases. MyoD1 and myogenin are positive, which stain the nuclei greater than 90% of cases. These are myogenic regulatory proteins, and vimentin stains positively. There's no reliable genetic study for embryonal rhabdomyosarcoma. However, for alveolar rhabdomyosarcoma, there's two characteristic translocations that result in fusion genes, the T213 and the T113, which results in PAX3-FKHR fusion transcript and the PAX7-FKHR fusion protein. This is showing you a rhabdomyosarcoma, basically a very heterogeneous tumor, but over here you can see this tadpole configuration. Look at that cell. It has a lot of cytoplasm, and it almost looks like a teardrop, and you can identify these types of cells throughout here. These are the rhabdomyoblasts admixed with small round blue cells. This is a higher power view of the same tumor, and you can see here the tadpole configuration of these cells. These are the rhabdomyofibroblasts, which have cross striations within them. This is a mitotic figure, abnormal mitosis, and then these are the small round blue cells of varying sizes and shapes, different than a Ewing sarcoma where it's a monotonous cell population. Here's very characteristic examples of the rhabdomyoblast. Here and here, a tadpole configuration with the cross striations within the cytoplasm. This is it almost looks like a trinucleated cell over here. This is a low power and high power view. And again, other just spindle cells or small round blue cells adjacent to these areas. Okay, very important to identify these cells for definitive diagnosis. High power view of the rhabdomyoblasts. This is showing you a positive desmin stain. This is a positive myoglobin stain. And here's an example of alveolar type rhabdomyosarcoma. On this low power view, you can see where there's almost these glandular or alveolar-like structures scattered throughout this sea of small round blue cells or spindle type cells. Again, it gives it somewhat, the alveolar form has somewhat of a glandular type appearance. Okay, and you would be looking for the characteristic chromosomal translocations with this tumor. You could also be looking for rhabdomyoblasts, which there may be one right there, and maybe one right there, and maybe over here. A little bit hard to identify. Okay, the treatment for rhabdomyosarcoma is wide resection chemotherapy and possibly radiation therapy. Preoperative chemotherapy is often administered for these tumors, and these tumors usually have a dramatic response to preoperative chemotherapy, meaning that they shrink down to virtually nothing. and sometimes there's nothing that can be detected on an MRI after giving the chemotherapy. It's very controversial then if you would perform surgery and or just radiation of the area. But the mainstay of treatment would be wide resection chemotherapy and possible radiation, and radiation depends on the age of the patient and location. The most common sites of metastases are to the lung, the lymph nodes, the bone, the brain, the liver. Other soft tissues can be sites of metastatic disease also for rhabdomyosarcoma. Prognosis differs according to the type. Embryonal rhabdomyosarcoma has the best survival rate, 70% disease-free survival at 5 years. Alveolar rhabdomyosarcoma has a worse prognosis than embryonal, with 56% at 3 years. Pleomorphic rhabdomyosarcoma, which occurs primarily in the adult population, has the worst prognosis. Majority of patients die within a year. The next soft tissue sarcoma we're going to speak about is leiomyosarcoma. Leiomyo means that it's of smooth muscle differentiation. It constitutes 9% of all soft tissue sarcomas. The median age of presentation is 40 to 60 years of age, and the most common site is the retroperitoneum. The thigh is the second most common site. It represents about 6% of all subcutaneous sarcomas, and it may arise from the wall of a blood vessel. The walls of your blood vessels contain smooth muscle cells, which may be the originators of the leiomyosarcoma, and the leiomyosarcoma may even obliterate the blood vessels. Clinically, patients usually have a painless mass. It usually does not cause pain. Radiologically, it presents as a nonspecific heterogeneous mass with necrosis and hemorrhage, similar to an MFH, similar to a synovial sarcoma, similar to a pleomorphic liposarcoma. Not much different from any of those entities. Histologically, you see a spindle cell tumor, and immunohistochemical stains are very important for differentiating a leiomyosarcoma from other tumors. The leiomyosarcoma is stained positive for actin and desmin in addition to vimentin. The treatment for a leiomyosarcoma includes wide excision and postoperative radiation whenever feasible. Okay, preoperative and or postoperative radiation is controversial. So for your OITE or your board exam, I think you'll just be tested on wide excision and radiation, knowing that both of them are part of the treatment. Okay, you would reserve an amputation for an extremity tumor where the tumor could not be adequately resected, or where a limb-sparing surgery could not be performed for whatever reason there is, whether it's wrapped around the neurovascular bundles, or it's recurrent despite radiation, or if there's been contamination from an inappropriately performed biopsy. Chemotherapy is also controversial in the treatment of leiomyosarcoma, but it may be indicated in selected situations. Okay, the leiomyosarcomas do metastasize. They are a sarcoma, and the first site of metastasis, or the most common, is the lungs, followed by the liver, the bone. It can metastasize to other soft tissues, and rarely to the lymph nodes. The prognosis for leiomyosarcomas depends somewhat on location. Extremity lesions have a 50% 5-year survival, and these are patients who present with tumors that are non-metastatic at presentation, meaning that there's no overt metastases detected at presentation. Obviously, the survival rate drops dramatically if there's metastases at presentation. Retroperitoneal lesions or tumors have a much worse prognosis. There's a 25 to 35% 5-year survival rate, and many patients with retroperitoneal tumors die because of local extension of the tumor. The tumor can grow, it can compress the ureters, and cause many local complications. Leiomyosarcomas again represent 9% of all soft tissue sarcomas. It's the third most common soft tissue sarcoma after MFH and liposarcoma. 20 to 60% occur in the retroperitoneum, up to 41% occur in the peripheral soft tissues, and may arise in association with blood vessels. The thigh is the most common peripheral location. The remainder of the tumors occur in the GU and GI tracts. They can arise from intestine. It occurs primarily in the 5th and 6th decades of life. Metastases are common. It has imaging similar to an MFH and Fibrosarcoma. Extremity lesions are usually intramuscular as opposed to intramuscular. Central necrosis and hemorrhage are common, similar to other high-grade soft tissue sarcomas, and calcification and actually osseous invasion are somewhat rare, which is in distinction to a synovial sarcoma. This is showing you an MRI of a Leiomyosarcoma, the vastus medialis muscle. This is the axial T1 and T2 weighted image. There is nothing specific about this MRI. The T1 shows a mass that's similar signal intensity to muscle here, and the T2 shows high and low signal areas or a heterogeneous mass. This is the same tumor with gadolinium administration, which shows diffuse contrast enhancement. A CAT scan of the same tumor, just showing a similar attenuation as muscle, and there's no underlying bony erosion and no mineralization within it. Nothing specific about the CAT scan appearance. This is a gross specimen of a Leiomyosarcoma that's been resected, and you notice that there's the pseudocapsule that's left in place. This arose from a muscle, probably of the thigh, and the entire muscle is removed and left as a pseudocapsule over the tumor. And I'm going to show you a few different views of this gross specimen. There's a deep side where you can see the muscle fibers splayed over the mass. And another view. This is an MRI of a subcutaneous Leiomyosarcoma. Again, nothing specific about the MRI appearance except that it's suggestive of a high-grade malignancy. This is a T1 and T2 weighted image where you see a heterogeneous mass projecting into the soft tissues of the forearm, or projecting into the skin of the forearm. This is the same tumor, administered gadolinium, and you see large areas of hemorrhage and necrosis that do not fill with the gadolinium. These are the necrotic areas. The areas that enhance with the gadolinium are the more viable areas. This is an MRI of a subcutaneous Leiomyosarcoma of the hand. This is a low-grade tumor. You see the tumor in this location. Again, another view. This is the axial T1 weighted image where there's a mass that's similar signal intensity as muscle, very small mass. This is with gadolinium administration, the mass enhances. And this is the T2 weighted image where it's very high signal on the T2 weighted image. Nothing specific about the MRI appearance. This is going to show you the surgery. This is a Leiomyosarcoma. It's affecting the subcutaneous tissue, so you have to take a wide margin. And this is the incision that would be utilized for resecting this. First, I separated the neurovascular structures from the underlying neoplasm. I identified them proximal to the area of the tumor, traced them distally, and then lysed any adhesions between these vital structures and the overlying tumor. This is showing you the separation from the underlying structures and the removal of the tumor that is subcutaneous in location. Again, another view showing you the vital structures that are intact along with the underlying muscles. And then a rotational flap that was performed, followed by a split thickness skin graft in this area to cover up the entire defect. This is showing you, I'm going to show you various examples of Leiomyosarcomas. Okay, this is one subcutaneously around the elbow. Again, the T1 and T2 weighted images are non-specific, very important to remember. This is just showing you nodular, firm appearing mass around the elbow clinically. Again, the surgery where a wide resection was performed, and you can see the underlying musculature. This is what the tumor looked like. A wide piece of the skin has to be taken with it. and then this is a tumor bisected. Okay, you can see a very fleshy tumor. There's areas here that look necrotic in nature, and this is the more fleshy, viable areas. Again, very white in appearance, fleshy, viable, similar to any other type of sarcoma. Fibrosarcoma can look similar. Synovial sarcoma can look similar. Other types of tumors can look very similar to this. Another example of a gross specimen. This is a low power view of a leiomyosarcoma. This is a histological sample, and again, a leiomyosarcoma is a spindle cell tumor. And what you're going to notice are nuclei that are cigar shaped. It looks like many of these nuclei are cut longitudinally, and some of them are cut in cross section where they look rounder. In the cross sections, you can often see some cytoplasm around the nuclei with some filaments around the nucleus, and in longitudinal section you may see corkscrew nuclei because of the contractile elements in the cell. If they contract, it kind of causes a nucleus to twist a little bit and shorten, which gives it a corkscrew appearance. You can't see this on this current low power view, but perhaps on some high power views you may be able to identify these cells. However, even though you can identify these cells, it's important to perform immunohistochemical staining of it, because it's what truly cinches the diagnosis, as leiomyosarcoma is stained positive for actin, desmin, and vimentin. Okay, this is an intermediate power view of a leiomyosarcoma, and again you can have cells that are cut transversely or longitudinally, and typically you see a halo around it. You may see some staining of other types of tissue here, and bizarre looking nuclei of different sizes and shape indicating malignancy, but nothing definitively here that indicates that this is a leiomyosarcoma. This is a high power view. Here's a mitotic figure, here's a mitotic figure, and often when leiomyosarcomas are cut transversely, you see this cytoplasm around it with these intracytoplasmic filaments consistent with the smooth muscle. You want to also look for cells that are cut in longitudinal section that may demonstrate a corkscrew nuclei from the contractile elements, which give it change it from a spindle to almost a corkscrew type shape. Again, some bizarre looking cells. This is not a normal cell. This should tell you right away that this is a malignancy. Cells are crowded onto each other, they're different sizes and shape, and then you have these cells with cytoplasm filled with filaments. So leiomyosarcoma demonstrating a positive actin stain. It's usually diffusely actin positive for the smooth muscle filaments. This is showing you a positive desmin stain for leiomyosarcoma. So again, leiomyosarcoma, positive vimentin, positive actin, and positive desmin. Here's a core biopsy of a leiomyosarcoma. You can see the shape of it. You can see that this is a hypercellular tumor with lots of bizarre hyperchromatic nuclei. It looks like a spindle cell tumor where there appears to be some fibers going in different directions. Higher power view showing you an intense amount of pleomorphism, anaplasia, and cells cut at different angles. Nothing specific for a leiomyosarcoma. You really would require the special stains. Here's a leiomyosarcoma in the popliteal fossa. T1 weighted image, very heterogeneous mass, nothing specific about it. Another view extending down below the knee joint. T2 weighted image showing you heterogeneous hyperintense mass. Another example of a T2 weighted image. I'm sorry, a T1 weighted image. This is the tumor when it was removed, again demonstrating you a very fleshy tumor. Nothing that is specific about a leiomyosarcoma. There's some hemorrhage and necrosis within it, but a very fleshy tumor. Here's the tumor cut in cross section. gross specimen and cross-section, and just a very fleshy, white appearing, solid appearing tumor. Nothing specific. May look mucinous in certain areas. And here's the histology of it. A spindle cell tumor. These nuclei are cut in longitudinal sections. Some of these nuclei are cut transversely. Nothing really specific about this specimen, and I'm looking for corkscrew-shaped nuclei. Perhaps that's a corkscrew-shaped nucleus. Corkscrew-shaped nucleus, perhaps because of the contractile elements and the nuclei coiling in nature. Fibrosarcoma can look very similar to this. Again, fibrosarcoma can look very similar to this. Nothing specific about it. This almost has a herringbone pattern similar to a fibrosarcoma. Again, a herringbone pattern similar to a fibrosarcoma. Okay, but the important thing about these transverse sections through these nuclei is that the cytoplasm surrounding these nuclei are usually filled with filaments that you can see on a high power view. An example of a Leiomyosarcoma, intermediate to high power view, looking for corkscrew shaped nuclei, which I don't really readily make out here, but nothing specific. We're going to have to rely on the immunohistochemical stains for accurate classification. Here's the actin stain of the core needle biopsy, which is diffusely positive for actin. Thank you. This concludes our lecture today on soft tissue sarcomas. I hope you learned a lot from this lecture. For more information on musculoskeletal tumors, please visit my website at www.tumorsurgery.org. There's also videos on the various surgical procedures, textbooks that I've helped co-author, as well as book chapters, and information on individual tumors. Thanks again.